Welcome back. Today we'll be discussing Chapter 24, which covers hematologic and renal emergencies. Now, a lot of our very sick patients that we're going to see have some sort of renal emergency going on. And once your kidneys do start shutting down, then you're going to have a lot more health issues progress, and these are very sick patients that we end up dealing with. So this is an important topic for us to discuss. So we'll first do a quick review of hematology, so the blood. Then we'll go into some things that can go wrong with the blood. Then we'll go into our renal system. So this stuff shouldn't look unfamiliar to you guys at this point, but we will review it. Again, I don't expect you to know the percentages by heart. Just know the overall, where the majority of cells are versus very little cells. So blood is made up of 4 different components. We have red blood cells, which is about 40–45% of our blood. You have white blood cells, which make up about 1% of your blood, platelets, which are less than 1%, and then you have plasma, which is about 55% of your blood. So plasma is the most of what makes up most of your blood, followed by red blood cells, and then your white blood cells and platelets are very little. There are some medications you can take that will affect the components of the blood. One of the biggest ones that we see are what we call blood thinners. Those are things that affect the ability of your blood to actually coagulate. So the blood has several different functions. It will be able to clot itself, so it controls bleeding. Its main function is delivering oxygen to the cells as well as other nutrients, and then removing our waste products, namely carbon dioxide, but also other waste products. They deliver them to the different organs which will excrete them. So blood clotting, again, this should be reviewed at this point. This is when platelets kind of come together and form a clot from the cell, so they stick together, and that is the body's most rapid and effective response to stop bleeding. So in order to clot, you need to have intact clotting factors. So clotting factors are proteins that are produced in the liver and released into the bloodstream. So that means if we affect our liver, then we can affect our ability to clot. This is why when people are intoxicated, it says, drinking will thin your blood out. That means that you will bleed more significantly if you are lacerated when you are intoxicated. That's because the alcohol is affecting your liver, and your liver is what affects clotting. So if we don't have a fully functioning liver, we aren't able to clot nearly as well. So that's things to keep in mind with clotting is it's done by platelets, but we need to have clotting factors. Most of those are produced in the liver. So coagulopathies are people who have abnormal clotting of the blood. Either they clot too much or they clot too little. So there are certain diseases that make patients more prone to poor clotting, such as advanced liver disease, because if we affect what produces our clotting factors, then we're going to have issues clotting. And then hemophilias, that's where we have just a baseline inability to clot well. Then von Willebrand disease is a bleeding disorder that is caused by having the low levels of clotting proteins in your blood. So all those will make it so you can't clot nearly as well. We do also have people who intentionally take things that we call blood thinners that will make it harder for you to clot. These are people that we are worried will clot more than other people, particularly if you remember cardiology, we talked about people with atrial fibrillation. We're worried about them forming clots more easily than others, so we put them on blood thinners to prevent that. So the disease anemia means that there's a lack of normal amount of red blood cells in the body. You can either have acute anemia or chronic anemia. Acute anemia is usually caused by bleeding of some sort. So if you're losing blood cells outside of your body or outside your bloodstream, then you can become anemic very quickly. So that's acute anemia. But there are some people who have chronic anemia. That's things that will happen over a long period of time. Some chronic anemia patients are ones that have diseases affecting the bone marrow, because bone marrow is where red blood cells are actually produced. But we also have people who have slow and chronic bleeding. So people have excessive menstrual periods or very slow GI bleeding can become chronically anemic. So talking about sickle cell anemia really quickly. Sickle cell anemia is a genetic disease, and it turns red blood cells from a healthy normal shape into kind of a sickle shape. We'll show you a picture of that in the next slide. It is a genetic disease, like I said, and it's very prevalent in especially African American community, as well as Indian or Middle Eastern descent. But really in our Black community is when we're seeing a lot of sickle cell anemia compared to other ethnicities. And again, that's because it's a genetic disease. When the red blood cells turn into a sickle shape, they have a very short lifespan, which means they die off quicker, which leads to anemia because we don't have enough healthy red blood cells. So here's a picture of red blood cells. This is what they're supposed to look like, and these are sickle cells. So you can see much less area, surface area on them, which means that it doesn't carry nearly as much hemoglobin as it should, which means it can't carry as much oxygen as it should. And like I said, they die off very quickly, which leads to the anemia. So complications that we see, we have destruction of the spleen. That's because the spleen is what removes our red blood cells from our body. If we are overloading it with these sickle cells, we're going to start to cause damage to the spleen. We have a sickle pain crisis, which we'll talk about in the next slide. Acute chest syndrome, which goes hand in hand with the sickle pain crisis usually. Stroke, jaundice, and poor perfusion. All this is because we do not have properly shaped red blood cells that can't carry as much oxygen as a normal red blood cell. So a sickle pain crisis is when you have intense pain, typically in the chest, but can be throughout the entire body. This is, when I say intense pain, it is intense pain. These people are hurting. It usually requires very heavy doses of narcotic pain medications to manage. There's certain hospitals that will only give the top tier narcotic medications to a few patients ever. Sickle cell patients are usually the ones that get these top tier narcotics that no one else gets. That's because of how much pain that they're actually in. And it's unfortunately a pretty chronic issue that they face. So 1 in 12 African Americans have the sickle cell trait, but that doesn't always mean that they're going to have issues. Most people with the sickle cell trait lead a perfectly normal life. Some people don't, but just because you're a carrier doesn't mean that you will develop sickle cell anemia in your lifetime. As far as our care of sickle cell anemia patients, we want to give them supplemental oxygen. That's because their red blood cells can't carry as much oxygen as most people can, so we want to let the oxygen be more prevalent for the red blood cells to pick up when they can. Monitor them for signs of hypoperfusion, because again, it's hard for them to carry the oxygen around. If you think they're having a stroke, which is again much more likely with sickle cell anemia, then treat them for a stroke like we discussed in altered mentation and neurologic emergencies. And then think about requesting ALS for pain management if needed. Again, when it comes to pain management, same thing that we talked about with abdominal emergencies. Make sure the patient actually wants pain management before you request ALS solely for the pain management. Some patients don't want narcotic pain management. All right, so going into the renal system. So as we know, the renal system has 2 kidneys. Each kidney has a ureter. Those drain into one bladder and then go out one urethra to the world. Our renal system is responsible for filtering our blood and getting the waste out of our blood and out of our body. It also plays critical roles in maintaining our fluid balance and our acid-base balance. It maintains our fluid balance by getting fluid out of our body, so if it notices we have too much fluid, it gets it out, and it also maintains our acid-base balance by getting too acidic or too basic elements out of our body. We excrete them through our urine. So it is a critical critical system in our body to keep things flowing well. If the renal system goes, you will die very, very shortly after. Typically with patients that are in critical condition in the hospital, particularly in the ICU, they heavily monitor their kidney function, and if your kidneys stop functioning normally, typically that's a sign that you're going to be dying in the next day or so. So there are a few different diseases of the renal system that we look at. Some of them are minor, but most of them are very life-threatening. So we're going to kind of start with the minor and go towards the more life-threatening ones. So we'll start with urinary tract infections. Again, we abbreviate this as UTI. So these are very common diseases. We see them more in females than males, and that's simply because the female urethra is a couple inches shorter than the male urethra. So when bacteria gets into the urethra, it has a much shorter way to travel to get into the body, versus males, it has a much longer way to travel, and usually you urinate before then, and that usually pushes a lot of the bacteria out when you're actually urinating. So they are caused by bacteria that get into your urethra. Usually it gets limited to the bladder, but it can spread to the rest of the body. It is a very common cause of sepsis, especially in the elderly when this is left untreated. Some of the main complaints we see in the mild UTIs are pain in the genitalia and frequent urination, especially pain when you urinate. If left untreated, like I said, it can lead to sepsis. It can also lead to kidney infections. So this is something that we do need to get treated relatively quickly, and if we treat it, it's usually a very minor disease. Again, this affects people of all ages, mainly females over males, but it absolutely can affect males. Next thing I want to talk about is kidney stones. So kidney stones is when there's a deposit of calcium that is formed. It gets bigger and bigger and bigger within the kidney. While it's in the kidney, you won't know it's there. So the kidney stone in the kidney is usually fine. You won't feel it at all. But once it makes its way to your urethra, you then have this very small tube that's supposed to transport fluid, and you put this calcified rock inside of it. So that causes a lot of pain. It's usually described as a flank pain. It can be tender on palpation, but usually isn't, and it can radiate to the groin area. A lot of these patients will have more pain when they urinate, and they will have difference in urination frequency or amounts, and that's because we are plugging one urethra. Or sorry, one ureter, not urethra. And so they're going to continue to have this pain as this stone moves down your ureter. It then goes into your bladder, and usually it goes out your urethra, and that's the end of the event. Our main goal with kidney stones is managing the pain during this process. A lot of times this is kind of just a wait it out type thing, which is unfortunate to tell patients that they just kind of have to wait out the pain until the kidney stone passes. But that's unfortunately what we really have to do. A lot of these patients should be transported to the hospital, especially for further pain management. So urinary catheters. This is where someone can't urinate well on their own. It can be a plethora of causes, but urinary catheters are relatively common to see now. So the goal is to go up through the urethra and sit in the bladder. Then there's a little balloon that gets inflated, and that seals off the bladder, and then urine drains through the tube all the way out the urethra and into a collection chamber. So they usually are placed in the urethra. They can be placed through the skin, but it's very, very common to see it placed in the urethra. That's called a Foley catheter. The complications that we run into with this is sometimes you can develop a UTI, and that's just because if bacteria gets into the urethra, there's no urination that will push it back out because urine is going through the catheter. And also we see local trauma, usually when the catheter is actually pulled out. Sometimes the balloon deflates and it just naturally comes out of the urethra, but sometimes, especially with patients with like dementia or patients who don't know what they're doing, they can grab it and rip it out of their body. If the balloon's still inflated, that becomes quite an issue, trying to rip that through your urethra. So it can cause quite a bit of damage and quite a bit of bleeding if you do that, and you'll see a picture of one in the next slide. So right here is a picture of a Foley catheter. So this part is what sits inside the bladder. This is what seals the bladder off. And then it comes out here through the urethra, and these are the ports for drainage and whatnot. So if a balloon this big gets ripped through your urethra, you can imagine how much damage that might cause. Next, we'll talk about renal failure. So this is kind of the meat and potatoes of this chapter, is talking about renal failure. So that's when the kidneys can no longer perform like they're supposed to. So they can no longer take the blood and filter it out and remove the toxins and get it out of our body. This means that we will keep our toxins inside of our body, and so this will cause quite a bit of issues with us. Chronic failure of kidneys is usually inherited or caused by some sort of other disease pathway, like uncontrolled diabetes or hypertension will typically cause chronic failure. An acute failure is usually from some sort of trauma. So it's some sort of traumatic event that causes this to happen because we have too many toxins suddenly flood our body, or we have some sort of shock or toxic ingestion. So that's acute failure where it happens very quickly, but chronic failure where we kind of develop over time is usually caused by underlying conditions. So renal failure, we start to see a lot of these types of patients when they get to end-stage renal disease. You'll see that abbreviated ESRD sometimes. That's where this is irreversible. So our kidneys have failed us to the point where they cannot adequately do the job at all, and they are not coming back. The only permanent treatment for this is to have an actual kidney transplant, which we will talk about in a little bit. But until then, you have to go through something called dialysis. So dialysis is when we take the blood out of the body, we clean it ourselves through machines, and then we put it back into the body. The vast majority of patients will do this via hemodialysis. There's also peritoneal dialysis, which we'll talk about in a little bit, but almost everyone goes through hemodialysis. So hemodialysis is done at dialysis centers, and your patients will go there for a very set, rigid schedule to receive dialysis. It's usually 3 times a week. So they'll go Monday, Wednesday, Friday, or they'll go, some might go Tuesday, Thursday. So there's a very rigid schedule that they have to follow. And unfortunately, this takes several hours to do. This takes like 2 to 3 hours, depending on the person. It could be a little bit shorter, it could be a little bit longer. So this is a significant amount of their life that they have to just sit there and have dialysis done for them, which is very, very, very time consuming, and it really limits their quality of life. Currently, there's around 400,000 Americans who are treated in dialysis centers, and like I said, it can last several hours, and it's usually 3 times a week. So an incredible amount of time commitment to renal failure patients. Only about 8% of renal failure patients treat themselves at home. That's because this is a very invasive and technical procedure. So talking about hemodialysis, so that's where we take the blood out through an artery. We then put it through a specialized machine, which will cleanse the blood, taking over the role of the kidneys, and then we put it back in through a vein. Again, this usually lasts multiple hours to do. You have to do this until you receive a kidney transplant. So here's a diagram of how it's taken out, the different machines it's run through, the different measurements are run through, and then how it's put back into the body. So there's 2 types of ways that we can access the blood for hemodialysis. One is a 2-port catheter, and then next is a AV fistula, which you'll see in the next slide. So an AV fistula stands for an arterial venule fistula, so AV, and these are usually placed in the arms, and you can usually see marks, so like here and here, or you can see right here and right here. There's another great one right here. So the goal with this is we connect into an artery, we then have an artificial graft, and that's what we will pull out of for dialysis, and then we connect back into a vein. So we pull the blood out of an artery, we put it back into a vein after it's cleansed through the hemodialysis. Right here is a 2-port catheter, exact same principle. This is the artery, so blood is taken out from the artery, it's cleansed through the hemodialysis, and then put back in through the vein. So there is such a thing called peritoneal dialysis. That's only seen in about 7% of dialysis patients in the United States. So it's not very common to see. If you remember, the peritoneal cavity is your abdomen. We talked about that in Renal Emergencies. And so we go into the peritoneal cavity, insert special fluid, let it sit there for several hours, and it takes all the blood that flows through that several hours and absorbs waste and excess fluid. We then pull that fluid back out and discard it. So that's another way that dialysis can be used, but it's not very common to see. So right here is a port used for peritoneal dialysis. You can see it's stuck in the abdomen. That's because that's where our peritoneal space is. So when it comes to medical emergencies and end-stage renal disease, we see things that are caused by the loss of the normal kidney function. So we have too many toxins build up, we have acid-base balance issues, and we also see complications of dialysis treatments. Again, keep in mind that most dialysis patients are undergoing dialysis because they had an uncontrolled underlying medical disease, such as diabetes or hypertension. Those are some of the very high risk factors for developing renal disease. So a lot of times, if a patient misses dialysis even by 1 day, they start to show signs of very significant things. So a lot of times you'll have very significant shortness of breath, you're going to have pulmonary edema, you might have pedal edema, you're going to have disruptions in your electrolytes. So this happens very quickly because you have too many toxins built up in your body. So these patients get very, very sick very, very fast. And so they will call for us because they are getting incredibly sick. So that's something that we do see very commonly. It is people who skip their treatments or missed a treatment, and then we are called usually the day of or the next day because they're having very significant respiratory distress problems. It resembles the signs and symptoms of congestive heart failure. So if you have someone who you think is having congestive heart failure, find out, do they have dialysis treatments? Did they go with their dialysis treatments? Is this what's causing all these similar signs and symptoms that we're seeing? So if you have a patient who's missed dialysis, find out when they were supposed to go, so how long it's been, and then do your standard ABCs. When you have a patient with a fistula, be very mindful that we do not take a blood pressure on the side of the fistula. Those patients should be able to remind you of that, but we don't want to be putting pressure on the arteries when we have the artificial graft in that arm anyway. So switch arms for your vital signs. Administer oxygen if needed. Monitor your vital signs very closely, and then bring them to a hospital capable of dialysis. Not every hospital can perform dialysis. So oftentimes the patient knows which hospital that they should be going to, so try to follow the patient's wishes and bring them to a hospital capable of performing dialysis, because they will need it in the hospital. And then if the symptoms require ALS evaluation, which they oftentimes do, go ahead and request ALS to at least evaluate the patient for you. So some complications that we see during dialysis is, number one, is the bleeding from an AV fistula site. This can be significant blood loss because we are connecting straight into an artery. Arteries move a lot of blood, so we can cause an arterial bleed. This can sometimes only be stopped with a tourniquet. We'll discuss that in soft tissue trauma of how to stop bleeds. But keep in mind that there can be a lot of blood loss. And also people with fistulas tend to have some issues clotting anyway. So not only are they bleeding straight from an artery, but we also have decreased ability to clot. So keep that in mind. You can also see some bacterial inflammation bacterial infection of the blood. That's because we are taking blood outside of the body and then putting it back in. It's much more exposed to the world than it normally is when it doesn't ever leave your body. So we do see a lot of bacterial infections of the blood, unfortunately. Again, when we're taking care of these patients, make sure your ABCs are intact, control the bleeding as best as you can, follow the guidelines that we'll teach you in soft tissue trauma, administer oxygen, and treat for shock. So keep in mind that kidneys are the most commonly transplanted organs. That's because kidney donors can donate one kidney and still live. You can work off of just one kidney. So there are about 16,000 transplants per year. That number is probably going to go up year after year. And again, it's because a donor can give one kidney and still live. After someone has received a kidney transplant, they have to be placed on anti-rejection medications. That's because you don't want the body to recognize that that's a foreign organ in you and start to attack it. So these anti-rejection medications are immunosuppressants. So if you take an immunosuppressant for the rest of your life, like you're supposed to, you're going to have increased susceptibility to infections. That means these patients are going to have a lot more infections. So be very aware that if they have received a kidney transplant, that they're going to be a lot more susceptible to getting an infection. We might be called for that infection. All right, so going into some chapter review. So blood delivers oxygen to the cells, removes carbon dioxide from the cells, and controls bleeding by clotting. Blood consists of red blood cells, white blood cells, and plasma. Anemia is the lack of red blood cells in circulation. Sickle cell anemia is an inherited disease in which a defect in the hemoglobin results in a sickle-shaped red blood cells. This mishappening inhibits movement of red blood cells through capillaries, causing sludging and blockages in smaller blood vessels. The renal system is comprised of the kidneys, the ureters, the bladder, and the urethra. The kidneys perform vital filtering of the blood to remove waste products. They also help maintain water balance within the body. Problems with the renal system include infection, kidney stones, and renal failure. Renal failure is a condition in which the kidneys are unable to filter waste and provide a balance of fluids and electrolytes in the body. Dialysis removes excess fluid and electrolytes from the body by filtration. Dialysis may be performed in either of two ways, hemodialysis or peritoneal dialysis. Hemodialysis at dialysis centers is generally performed 3 times per week. Peritoneal dialysis is usually done at home and is usually done several times daily. Major complications in patients with end-stage renal disease can occur after the patient has missed a dialysis appointment from infections or as a result of bleeding from hemodialysis access sites. Remember, blood has specific cellular components. Abnormal blood cells can significantly affect patients. The renal system is critical to maintaining homeostasis. Renal failure can be chronic or acute. End-stage renal disease is managed through dialysis. So you should be asking yourself, does my patient have a history of sickle cell disease or end-stage renal disease? Does my patient have an AV fistula? Well, I need to make an early request for ALS because of complications from a missed dialysis appointment. So you have a patient who is transported routinely for dialysis 3 times per week. She was sick and canceled the trip yesterday. Now she calls saying she can't breathe and feels like she's going to die. Is it possible that she has a legitimate complaint after missing dialysis by only 1 day? Absolutely. Missing dialysis even for a couple hours can cause very serious life-threatening problems. This is a very typical call for us to receive. So this is something that you will see in your career, is someone who missed dialysis 1 day ago and is now feeling like they can't breathe and that they're going to die. That's because they are going to die if they're left untreated. So this is something that we don't mess around with. Kidneys and the renal system are vital to us being able to survive. Like I said, and if a patient's in the ICU, if you're kidney function goes down, that's usually game over. That means you're probably going to be dying in the next day or so. So keep that in mind, that this stuff is very, very important for us to be able to live. If you can't get the toxins out, you will die very quickly. So with all that being said, this is something that we will see a lot in our careers, so make sure that you understand this pretty well so that we can best assist these patients. So until next time.